I'm an academic GP, so I work on the other side of the city a couple of days a week, seeing patients as normal as a GP, and then the rest of the time at RCSI, leading a group that's interested in some of the issues that you're interested in terms of prevention, early detection, screening, and so on. There we go. Yeah, so just some simple disclosures in terms of us. We're very grateful for many people in this room in terms of funding us to do this work, and just acknowledge them. I'm kind of conscious that this is where primary care sits, really. So to my mind, and I don't think we're overclaiming it, but really across the continuum in terms of patients' journey. And I say primary care, obviously I'm a GP, I'm only one element of what primary care is. We've already heard that this morning in terms of primary care workers working with PAVI Point and so on. We're particularly interested in this area in terms in the middle that I've highlighted in terms of optimizing screening and thinking about diagnostic routes and earlier detection and so on. But I think appreciate the title of this network. It's a continuum. So where people are on that journey, it moves back and forth. So a lot of what I'm describing today is very relevant, I think, to prevention as well as screening and into diagnosis. So a guide for us as we're kind of trying to work on some of our projects and detail them more in terms of what's driving things is this theoretical framework, which comes from colleagues in the UK, which I think informs a lot of our projects. So thinking about what is the particular tumour that we're looking at and what are the specific disease factors related to that. What's happening in terms of patients. So Alice would appreciate this in terms of the behavioural science, and we've really had to build out our expertise in that area as well to understand why it is people participate or don't and the choices they've made. And we heard some of that, I believe, earlier on this morning as well. And then finally, obviously, the system and people like myself working as a GP and what are the gaps and the potentials to optimize time to diagnosis. If you haven't, I really recommend another wonderful organisation that is the CRUK. I'm sure many of you are aware of their work, but they have a strategy document around early diagnosis that's worth, certainly been inspiring for me in terms of thinking clearly about where we can be most effective in terms of designing some of our projects. So just from top down, just calling them out really is thinking about the existing screening programs and how we can better optimize them, and we've been doing some work on that. How we can think in a more targeted way. So you've heard this phrase of precision medicine or personalized medicine. So how can we target existing screening programs? And as I'll show you shortly, how we can develop new ones that take that more targeted approach. We've been doing some work commissioned by the NCCP to think about awareness campaigns. So as I was saying in the break, there's a lot of money spent on cancer awareness programs, and if I'm honest, we're never quite certain if they're working or not, and where are they working in the causal pathway. And so that's a piece of work that we should complete early next year that will try and do some of the quantitative analysis of that. And then we're doing work on existing referral pathways. So we have some rapid access pathways at the moment. How are they being used? Are they being best used? Is there variation in care? Why is there? Could they be improved upon? And so we have a couple of projects in that space. And then finally, in terms of innovation, that's probably where I'll spend the rest of the talk, is talking about new developments, whether that's screening technologies or blood biopsies that you probably heard about, these kinds of things, and how they can be integrated into into the system. Okay, so let's talk about lung cancer then. And again, a knowledgeable audience, so I appreciate we can move through this relatively quickly. It is the #1 contributor in terms of deaths, both here and internationally, and it is labelled as a poor prognosis cancer along with a couple of other tumour types because its performance over 5-year survival is quite different than some of the other major cancer types. And you can see the improvements over time. While there has been improvements over time, there's still a long way to go. And so that's why you hear a lot of discussion about it as being as a target tumour type to try and see how can we improve upon it and recognise what are the issues. So it's really, again, thinking about that poor prognosis, it's because by the time I see people in clinic and Una sees people in clinic, they've already got symptoms that mean they are quite far gone in terms of the stage of development. So stage 4 is a very common diagnostic stage for tumours, so hemoptysis and so on. So the idea is trying to move people back to an earlier stage, and hopefully that will have an impact on cancer outcomes, so early diagnosis. I just put this slide in because, well, I think it really resonates with my experience, and I suspect many others in the room. And it's not specific to cancer, although in this case I'm talking about the NCRI figures around lung cancer, which is just talking about that social gradient. So that in those who are more deprived, the incidence is higher, and those who are more deprived, the mortality is lower. So again, you're probably nodding your head going, of course, Patrick. And I know that this is seen in other conditions and diseases and so on. But I think why I'm pausing for a second is because anything we do subsequently, we need to appreciate there are certain parts of the population that are going to be more affected, and we should try and think about how can we incorporate them, whether that's back to behavioral science or the disease itself. Okay, so what is the innovation? I've kind of labored long enough, so let's talk about it. So screening. So what are the opportunities in terms of lung cancer screening? People have been working on this for a very long time, actually. So you'll know chest x-rays, so people have tried chest x-rays as a way to screen. So if we sent everybody for a chest x-ray, could we find some of these lesions earlier? It doesn't work. What does work, and I'll show you the evidence that it does work, is low-dose CT. So everybody knows CAT scans, the donut that you lie down and roll into, and then maybe the only real additional development on this is that it's a low-dose version, so low dose of radiation. They say equivalent to a year's worth in the sun, and that's what low-dose CT is. And so it's done in a targeted fashion, and I'll tell you more what I mean about that, but it's back to that earlier comment that to make an effective screening program, you need to make trade-offs in terms of thinking about who are the people who would benefit most. And we'll talk more about that. So does it work? So New England Journal of Medicine, everybody knows that one. I will someday hopefully see a paper there. These aren't my papers. These are people who have successfully shown that lung cancer screening does work anywhere. Different meta-analysis talk about different things, but something like 20% reduction in lung cancer mortality. 20% reduction in lung cancer mortality. Original studies were done in the US in National Lung Screening Trial, and then Nelson came afterwards in Europe, and it's been repeated in other studies, and as I said, there's been meta-analysis to confirm that across many. So the evidence is there, we know it works. So now it shifts into another stage of research, which is about implementation. So you've heard this topic about implementation science. Often we have these fantastic innovations and they don't necessarily get to the patient, or it takes a very long time, and you need to appreciate why that is. So that's what we're doing here. So this is Solace. So again, I suspect some people know about Solace. So EU for Health is a major funding program from the EU that has funded, in the past year, has funded 3 big new screening initiatives. Solace being one for lung cancer, and Praise You for prostate cancer, and TOGAS for gastric cancer. So big initiatives, millions and millions being poured into this to try and develop these programs. What it looks like for us in Solace is that we're contributing to about 15 other countries, all pooling our experience and trying to learn from each other about how we go about implementing this innovation. And so some countries are at different stages of development here. So some countries like Croatia already have an established national program. The UK has just approved a national program. Germany has many successful pilots, and then Ireland obviously doesn't have one. So that's what we're trying to learn from. So we're contributing in work packages 4, 5, and 6. I'm sorry, people at the back of the room are probably nodding off going, I can't see the screen, this is too small. And those of you on camera, you're getting a bird's eye view. So 4, 5, and 6. So what we're doing here with these pilots is trying to think about particular groups that the designers of this program were interested in, thinking that they might be vulnerable. And again, back from the conversations at the break, is thinking about minority groups, thinking about there's a potential for a gender imbalance, thinking about rurality as a potential difficulty for people to access services. So that's what's been drawn out in some of these work packages. And so we will be contributing data to these work packages, and others have already started. Okay, so what does it look like? What does a successful lung cancer screening program look like? So that's not breast check, which is the model actually, though. It is learning from the model of breast check, which is that mobile truck being near to the patients, based in the community, and that's what works well. So you've seen different options. This one is from the UK, so in Manchester Stadium, this is what we will be replicating. So we've pretty much taken the copy and paste version of this because it's the most successful version in terms of screening uptake, which, as you know, is the kind of one of the key metrics in terms of whether the screening program works. I just got a 5-minute warning, so we're going to have to move fast. So it will be targeted, our pilot will be targeted at 55 to 74-year-olds. So now I'm getting into this idea of people who are at higher risk. People who are higher risk for some fundamental reasons: age, gender, and smoking. So it is targeted at those kinds of groups. It's called a lung health check, probably to address some of those issues around stigma. So about calling it a lung cancer screening. So it's a lung health check. You get more than that. You get smoking cessation advice, you get spirometry to detect COPD or chronic obstructive pulmonary disease, and a few other bits and pieces. These are the models in terms of how people eligibility would be determined. So it's a regression model that you input all these variables and you come up with a threshold, and the threshold determines whether you're in or not. I'm just going to keep moving. So because I want to talk about a few more things in the last 3 minutes that I have left. So screening uptake, I've already said to you, this is one of the major challenges for us. And that's why I'm delighted to work with Alice on some funding from the HRB that was just awarded a couple of days ago to actually think about this issue. Because, for example, in the US, screening uptake can be as low as 6% in lung cancer screening. It's higher in the UK, but it will fall over if we don't make it work. There's other issues. So this nice graphic from a colleague in London describes challenges at all stages of the lung cancer screening process. So how do we, back to that idea of awareness and fear and fatalism, so how do we work with a community to help them to be motivated to participate? And there's a whole behavioural science framework around that. How do we use the GP practices and their relationship with their patients and their GP data sets to identify high-risk individuals? How do we invite people? How do we conduct this eligibility assessment? Where do we set that threshold? You know, what determines what people should be in or not? How do we do shared decision making? How do we work with people to think this is a good choice for you or this is not a good choice? And then retention. Okay, that's just restating the point. A few more bits I just want to get through because you're going to stop me at the back. This is just to let you know we are working on it. We've got various research projects underway already, so these are published protocols. And a big thing that you probably want to talk about is incidental findings. Of course, if you scan people, you're going to find lots of things. And so we do appreciate this, and actually there's lots of we have lots of experience from international collaborators, not just the UK, to show us what this is looking like. And we're planning within our pilot to appreciate that coronary artery disease, COPD, adrenal adenomas, and all these kinds of things will show up in some of these scans. And how do we handle them, and how do we appreciate the psychological impact of that? Pros and cons. So this is probably one of my last slides really, which was Murray Gray, who was a very famous physician from the UK. He had this statement about all screening is harmful. I know I said this to you before, Liz, when you had an event, and I know you were a bit shocked when I said it, but there's a second part to this statement. So all screening is harmful, some screening is beneficial, some is more beneficial than harmful, and some does it in a cost-effective fashion. All that's to say is that you just need to appreciate that there's a cost benefit to all of these interventions, and that we need to do the work to understand, if you screen all these people, what unintentional harms are you going to create? What potential for overdiagnosis is a concept? So we have 2 or 3 health economists now recruited to work on this exact issue, which I think is very important and will definitely be relevant to Ireland if our pilot becomes a national programme in time. We will need to understand this for Ireland about how we want to run our programme. So last slide is this. So our pilot will shortly be commencing. I'm sorry I can't give you a huge amount of detail. You probably appreciated that because there's an embargo in terms of media about it, but it will be relatively large and scanning about 2,500 people with everything I've just described. The questions from a research program that we've already begun to work on is, as I've said, so what are the most effective recruitment strategies that address issues like equity and avoiding marginalizing groups even further? How can we use particular novel technologies like mHealth to recruit people into screening programs? The risk assessment and intervals. So where is the appropriate threshold for people to be recruited? Biomarkers. So we have a biomarker program built into this. So how can we use some blood tests to again, risk stratify people? And there's a machine learning package within that. It won't surprise you to hear. And then the modeling and the thresholds. We've been working with some Dutch group around this who have had lots of experience around the cost effectiveness. And again, that will be a key question, for example, for the NSS in the future if they wanted to adopt our pilot as a program.